Bismillah ar-Rahman ar-Rahim. Thank you, Mr. Chairman. It's my pleasure to present this case in this meeting. Always I have a pressure on time during my presentation. But also we should have pressure on time for early recognition of this rare complication, especially post-myocardial infarction with instability. And so we should suspect rare post-MI complication. Our patient actually is a young patient, 33 years old, Yemeni, male patient, heavy cigarette smoker, no medical illness before, presented with 1 hour duration, chest pain, shortness of breath, sweating, ECG done, showed ST segment elevation in the anterior leads, and we gave him thrombolytic therapy, tenecteplase, IV bolus, 50 milligram, according to body weight. But 1 hour later, patient still having chest pain, hypotension, persistent ST segment elevation, and congestion orthopnea. So we discuss the case with ER team, rapid response team, and cath lab team, and we decide to make elective intubation, mechanical ventilation for taking the patient to the cath lab for rescue PCI. His left right system showed no significant lesion and also no collaterals to left system. His left system showed still persistent occlusion of the proximal part of LAD, grade 5 thrombus burden, as all of us know, after thrombolytic failure. So immediately I passed wire, BMW wire, but the wire went to the diagonal branch. At that moment, and always this is my practice, when you are sure that the wire went to the side branch, you can easily use what we call the side branch technique, whether acute setting, subacute setting, or even CTO setting. So you can inflate balloon, small balloon, 2 or 1.5, then you can redirect easily the wire after geometrical shift and thrombus deformation. And this is actually what I did. I inflate small balloon, and then we can clearly now delineate diagonal and the LAD, and easily we can make redirection of the wire to the main vessel. We make reposition and inject intercurrent medication and inflation the balloon again at high pressure, and this second wire to secure the diagonal branch. And I felt there is high burden of thrombus actually, so I make aspiration and this red thrombus after aspiration. So we comes to decision making about the stenting, whether crossover stenting or the precise ostial stenting, especially in our patient with wide angle more than 90 degree, normal left mean, normal ostial circumflex. So I decide to make a precise ostial LED stenting 0-1-0 Medina classification. So I deploy Resolute 3.5 by 28 at 16 atmospheric pressure. And this is the final results. And the procedure done smoothly without any complication within 15 to 20 minutes maximum. Then I insert intra-aortic balloon after I finish the procedure, and ECG done immediately after the procedure. We noticed significant reduction of the ST segment elevation after we make revascularization of the occluded LAD. And we transfer the patient and endorse the case to ICU team, mechanical ventilation, intra-aortic balloon, torfepan, norepinephrine, patient stable. Then I went for vacation for 7 days. When I came back from the vacation, I get surprised. Patient after 7 days is still in ICU and still refractory cardiogenic shock. And ICU team cannot wean from mechanical ventilation or intra-aortic balloon. So, flashback story of this case, I asked our fellows and our colleagues in ICU, patient developed cardiac arrest 6 hours in ICU after the PCI. He had 4 minutes cardiac arrest, CPR done, VTAC, VF, DC shock given, and revived with severe cardiogenic shock. Actually, then they give him epinephrine in addition to norepinephrine. Then the question is still for me. Why is this patient having persistent refractory cardiogenic shock 7 days after successful, uneventable rescue PCI? I reviewed the echocardiography, and this is the surprise. Echocardiography in the second day after the cardiac arrest and PCI showed minimal pericardial effusion, just 0.5 millimeters. But there is early diastolic collapse in this case, actually, when short axis showing the proximal RVOT and distal RVOT, and it is in the early diastolic. It is actually the first segment to be affected in minimal pericardial effusion with tamponade. And you should not forget this statement. Pericardial effusion, minimal, 0.5 millimeter, 100% sensitivity to diagnose mechanical complication in the setting of the unstable STEMI patient. And this is for a chamber. There is type 1 free wall rupture, slit-like dissection and tear in the wall, in the apex, and echo again repeated after 4 days. And more progression of this dissection of the wall and more infiltration of the myocardium, more canalicular damage of the myocardium after 4 days, and still the case missed actually for diagnosis. After 5 days, they doing a transesophageal echo for this patient, and transesophageal echo does not mention anything about the rupture of the wall. We should remember also that transesophageal echo is less sensitive in diagnosis of the rupture of the wall. It is 70% only sensitivity. So I requested a new updated echo, and there is a big surprise. There is more rupture in another location, in the lateral segment, which is actually the most common site for rupture in the poor collateral area as the terminal territory of LED, and it is clear here in this image, actually. And despite all these images, still some debates from our colleagues in ICU team. So we decided to go for contrast echocardiography to confirm the diagnosis. And contrast echocardiography confirmed type 1, type 2, and even type 3 dissection and rupture of the wall of the LV. And we should differentiate between the true aneurysm and the pseudoaneurysm. Of course, pseudoaneurysm, there is complete dissection of the wall, like our clear image from contrast echocardiography in this case. Not only that, myocardial contrast echocardiography showed large perfusion defect, which actually reflect the extensive microvascular damage and hemorrhagic transformation, which is high risk for the mechanical complication and miss in such a group of patients. And this study showing the extent of microvascular damage by myocardial contrast echocardiography, which is superior for detection of this myocardial damage of the microvasculature, especially what we call the sustained or refractory tissue neuroflow, which is having high 30-day mortality. And after discussion with the heart team and surgical team, they decide to downgraded the patient to conservative management. They claim the patient having friable apex, friable myocardium, all area are multi-site rupture, multi-location, multi-canalicular, and also we have doubt that there is some serpiginous rupture, also encroachment the RV as well. So they downgraded the patient, and unfortunately the patient died after a few days. So free wall rupture, it is not uncommon and reported in many registries, including the shock trial registry. And there is a long list of risk factors, including the advanced age, female gender, delayed perfusion, failed thrombolysis, failed primary PCI, first transmural MI, anterior or lateral and poor collaterals, hypertension, use of non-steroidal and steroidal, and especially in presence of triggering factor like persistent hypertension or persistent coughing and constipation, vomiting and agitation. And there is different types of this free wall rupture. Our patient, unfortunately, having all these 3 types evolving over 7 days. And of course, the worst scenario is the acute blowout type. Patient can die within a few minutes. And the subacute type can tolerate a few minutes to hours, and then the chronic that continue with LV pseudoaneurysm. And this is updated of the blowout type and the oozing type and the pseudoaneurysm approach, according to last published papers a few months back, show that the surgical candidate patient blowout type and oozing type, we should use mechanical circulatory support and surgical intervention immediately, while pseudoaneurysm type, we can go for surgical candidate patient without support or percutaneous if it is eligible. So take home message, free wall rupture is rare, unpredictable, underestimated catastrophic complication. High clinical suspicion is crucial for early recognition. And of course, it is sometimes challenging for diagnosis. So detailed analysis of the echo and even multimodality use should be used for confirmation of diagnosis, and minimal pericardial effusion, even 0.5 millimeter, 100% sensitivity to suspect there is free wall rupture. Thank you.
دكتور أحمد